Great. Good morning. Thank you to the SMSNA for the opportunity to discuss this. We're going to switch gears a little bit from penises and vaginas and talk a little bit about some more social things. But my name is Tom Gaither. I'm a T32 fellow at UCLA. Clinically, I focus on reconstructive urology and sort of all things LGBT urology. And my goal for this talk is really to expand your knowledge and relieve a little bit of discomfort and also improve your ability to connect with your LGBTQIA patients. So I don't have any disclosures. So this is what we're going to talk about. I'm going to talk about all the LGBT spectra and the psychological burdens that are somewhat unique to this population. We're going to talk about recommendations for collecting sexual orientation and gender identity. We're going to talk a little bit about hormone therapy among transgender individuals, surgical therapy, and then some future directions and some controversies. So this acronym really just represents human biopsychosocial sexual diversity. And our diversity really begins at birth with intersex. And these terms are often used as identities. And these identities have historically and in our current day been stigmatized. And when it comes to urologic and sexual complaints, I guarantee that these identities are impacting how your patients are presenting. And what happens in the office typically does impact what happens at home. And everything is a spectrum. So I'll say this a few times, right? So this is the famous, genderbread person that helps to display some of these concepts of gender identity, biological sex, sexual orientation. And for example, I know most people know this, but sexual orientation is who you are physically attracted to. And some people that's purely the opposite sex, some people it's the same sex, and a lot of people are in the middle. And just remember, this attraction, it's not always behavior. Sometimes it's just thoughts, and sometimes it can be identities. So I wanted to talk about some other important spectra that go along with these identities. And the first one is outness. Does your patient, are they out only to themselves, or they're unaware, or are they out to their friends, their family, and their professional life? And this was a really good study, kind of a famous study on outness, that looked at the degree of outness is directly correlated with alcohol use, and it's sort of inversely correlated with our bisexual patients. So it can be a double-edged sword. And then what about distress over your identity? Again, this can be ranging from self-hatred to acceptance to being an advocate for this. And one good example is internalized homophobia, which has been consistently linked to substance use, suicidal ideation, and even things like anal dyspareunia, which is my particular area of expertise. And then what about motivations for sexual behavior? Now this is in all of our patients, not just our LGBT patients, but it can range from being mindful and intentional to compulsive. And compulsive sexual behavior has been consistently linked with chemsex, HIV transmission, and the use of ED medications. And then gender dysphoria. Now it's important to note that not all transgender individuals even have gender dysphoria. But many of them do, and it has been associated with a lot of terrible things like depression, anxiety, suicide risk, etc. Now, another common experience among LGBT individuals is childhood victimization and adverse childhood experiences, or ACEs. I'm not sure if are familiar with this literature, but the ACEs literature is big. Now, for reference, among non-LGBT individuals, these rates are typically about half. And many state that things like family rejection are a common reason for these higher rates. So if you hear that one of your patients are struggling with things like coming out or having distressful thoughts about being gay, sexual compulsion or gender dysphoria, and childhood trauma presents in many, many, many different ways, really you do not need to be a mental health provider to ask, acknowledge, refer. Okay, switching gears, so how do you ask about sexual orientation? So here's the recommendation from the NIH, or I guess what used to be the NIH, I can't keep up anymore, but which of the following best represents how you think of yourself and then there's some answers there. I usually add a free response to this as well, because some people like to add something, and it's not, sometimes it's a little bit too limiting. And then what about sex and gender? So there's actually a large amount of literature about how to ask these questions, and the NIH generally recommends the two-step method, and this really avoids assuming that everyone's gender aligns with what was assigned to them at birth. So my only qualm with this is I would add just one space for a non-binary, because I think it's popular enough or common enough that it deserves its own response. But at the end of the day, knowing your patient's sexual orientation or gender identity doesn't always tell you more about these granular details that you need to know clinically. So if you want to know how to address you, or what hormones are they on, or what organs do they have, I really just recommend asking them. I wouldn't assume anything from their sexual orientation or their gender identity. And if you pay attention to one slide, this would be it. So I see a lot of LGBT patients, and I get a lot of people saying, my doctor just didn't quite get it. And these are the common things that I hear. Number one is I would just have some mechanism to ask patients about their pronouns and just use them. Misgendering patients can be quite triggering for some people. Number two, I would familiarize yourself with what is PrEP. It's basically a daily medication or a monthly injection that people take to prevent HIV. And it's been shown to be very efficacious in randomized controlled trials. And number three, I would just use gender-neutral terms for the partner instead of saying, wife or husband, etc. And number four, I'd be open to discuss diverse sexual practices, and a huge one is anal intercourse. Now switching gears about hormone therapy, so both masculine and feminizing hormone therapy can be utilized for transgender individuals as a part of gender affirmation. Now the exact regimens are a little bit beyond the scope of this talk. I don't prescribe them. Usually it's the endocrinologists or the primary care doctors who do this. But the goal of HRT in these individuals is to help align physical characteristics with their gender identity. And there are a multitude of studies that show the benefit of HRTs, but I'd like to highlight one of them. And this was a randomized controlled study out of Australia. 64 patients were included, and they were randomized to immediate testosterone or a delay, 3-month waiting for their visit, and then initiation afterwards. And the immediate group had a significant decrease in gender dysphoria and a large reduction of suicidality. And I think longer-term data, of course, is needed, but I think we'd be hard-pressed to find an intervention that has such stark psychological benefits. And then surgical therapy, so gender-affirming surgical therapy helps to align physical characteristics with gender identity, and of course the added benefit of aligning oneself sexually with bottom surgery. And there are guidelines for who should get surgery, and it's all set by WPATH, which is the World Professional Association for Transgender Health. Now, there's a growing literature of the following things, and these are actually well described: complications, functional aesthetics, urination, orgasm after these surgeries, psychological well-being, patient satisfaction. So there are multiple studies on this, but I think the area that we need more things in is to go away from this one-size-fits-all approach. I personally find it difficult to find who is ready for reconstructive complexity and who is not. And what does that mean? So who do we need to do phased approaches to, and kind of managing unrealistic expectations about the surgery's impact on happiness and esteem. So here are some remaining questions, and I think we'll be seeing more of this in the literature and in the meetings coming in the future is, how do we screen for GU cancers? There's been several case studies, case reports of prostate cancer in transgender women, and I think we'll have some more guidelines with that coming in the future. And, pediatric gender-affirming care is outside of my personal scope, but it is evidence-based, ethical, and associated with improved mental health outcomes, and it is backed by several major medical organizations. However, despite all of this, it is a very politicized issue, especially now. And I think it overall reflects our society's real discomfort with the idea of what is gender and gender diversity. And then anal dyspareunia, which is, again, my particular area of expertise. We are working on sort of how do we better define this, how do we recognize it, and how do we treat it in our patients. And a lot of urologic diseases impact this: chronic prostatitis, pelvic floor dysfunction, prostate cancer treatment. So I think we're going to see more of this. So here are just some takeaways, and there's also a handout there if anyone would like that. But sexual and gender diversity are normal, and it spans multiple spectra. Everything is a spectrum in this area. And minority stress, internalized stigma, and trauma are common, and I believe that these are clinically relevant. So asking about them, I think, is very important and will be a way for you to connect for your patients. But anyways, the field is evolving, and we're just scratching the surface, and I think urologists are the key persons to help move this field forward. So I thank you for your time.
I don't know if I'm allowed to ask a question, but I'm asking it anyways.
Sure.
First of all, thank you, Tom. Beautiful talk. Tom spent time at San Diego. He's a fellow, and I invite other fellows who are doing fellowships to spend time with us. The anodyspareunia is the most fascinating concept, because the transition from women who have lots of dyspareunia and men with anodyspareunia, it seems like there could be a lot of parallels that could be expanded upon. And I think the region-based approach that we've developed in women's sexual health issues would be amazingly applicable here. I don't know if you have any comments, but.
I appreciate it, Dr. Goldstein, and I think the regions-based approach is probably how we'll figure this out. I wish we could show some more data on this, but absolutely, a lot of parallels between the receptive partner and female sexual dysfunction is very common in what you see in male sexual dysfunction of anal dyspareunia. So appreciate it. Thank you.